yeah, we'll have the... So this will lead on to systemic treatment. Paris has talked about local therapies that we can use. Now we'll talk a little bit more about systemic. I have no commercial disclosures. Just to remind us about steroids, probably still our number one agent, systemic steroids probably. What are the side effects of long-term steroids on a patient? And these are some recommendations from the European Rheumatology kind of league. And this is low-dose, long-term oral prednisolone, up to 7.5 milligrams of prednisolone daily for average weight individual. Hypertension, stroke, there's probably no increased risk. We don't have great data on a lot of the other side effects, but there's probably an increased risk of diabetes, osteoporosis, hip necrosis. But our data is actually quite poor, partly because steroids have been around so long. If they were brought in today, they'd be much more rigorously scrutinized. One thing I would say is if you want to make patients miserable, keep them on long-term steroids, because the effect on mood is really significant. And I think we don't appreciate that as clinicians. So anyway, it kind of takes us on the indications for immune suppression. I suppose you might call this steroid-sparing therapy. And you can split this up into several groups. You may need an unacceptable steroid dose to control the disease. That would be number one. Number two would be an acceptable dose, 5 milligrams or 7.5, but just unacceptable side effects. It could be mood, depression, gastric ulceration, osteoporosis, severe osteoporosis, diabetes, for example. Number three, we know there's some diseases that don't respond very well to steroids. Behçet's is one of them. It's hard to figure out what the other ones are. But there's maybe birdshot, maybe VKH, some diseases that are full of poorly responsive. And then the other thing is perhaps we want to use an agent that's going to cure the patient, disease modifying. And that very few of our drugs can do this. Alkylating agents, which we rarely use these days. I'm not really going to touch on those, but they can. Some biologicals and some diseases, I think would be fair to say. Okay, a lot of patients ask if you're going to suggest an immunosuppressive drug. I mean, you know, they want to know what the long-term risks of these medicines are. Am I going to get cancer, doc? And they may not ask you, but you can feel that they want to know these things. They read about the side effects, they worry, oh, it's going to depress my immune system. So we have some good data. This is John Kempen from the SITE study, and it's the latest one was published at ARVO this year. Retrospective, a very, very large cohort study. 16,000 patients followed up for, I can't remember, about 9 or 10 years or something. So we got 180,000 patient years, one patient taking one immunosuppressive for 1 year, a huge database. And they looked at a couple of questions, basically increased risk of death and then increased risk of cancer incidence in these. So these were uveitic patients on immunosuppressive drugs. Well, the good news is that they couldn't find any mortality effect. Basically, if it's on the one, there's no excess risk. And these are the error bars. You know, some pretty wide error bars for some of these. But they're all kind of lying along the line here. Okay, the tacrolimus was the only one that came out a bit. But if you removed patients who had systemic disease, so this could be quite a nasty, like polyarthritis nodosa, or some systemic vasculitis that's probably life-threatening, then it sort of normalized. But generally, there was really no signal for most of the drugs we're familiar with. That's good news. What about the cancer risk? Again, we will never get a better database than this, probably. Again, they could find no overall increased risk of cancer mortality in our patients. So this is really important. And it did include the original data some years ago didn't really have any on anti-TNF, but now we do have data on anti-TNF. They are safe drugs to use, and that mirrors the experience in rheumatology, for example, and inflammatory bowel disease. Okay, so they couldn't find an increased risk of overall mortality or cancer risk. One What about conventional drugs? Well, is anything happening, anything new? Well, this is a very interesting trial called the FAST study, and it was a pragmatic randomized control trial that looked at methotrexate versus mycophenolate, two common drugs that have been around for 50 years, very cheap drugs, and probably our number one kind of immunosuppressive drug, widely used, and just a head-to-head, one-to-one, how do they do? So it was prospective randomized control trial. They used, it was 9 centers in sort of Mexico, US, one in Saudi. They used a pretty big dose of methotrexate, 25 milligrams a week, and they used quite a big dose of mycophenolate, 3 grams daily. So they went straight onto high dose. And they looked at sort of treatment success at 6 months, control of inflammation, basically, ability to taper the steroids, taper the topical prednisolone drops, and these were their kind of key endpoints. And the bottom line is that there was no difference between methotrexate or mycophenolate in terms of efficacy. Slightly more with the methotrexate, but it wasn't significant. And again, in posterior uveitis, the methotrexate had slightly more success than the mycophenolate, and that was significant. But broadly, both drugs were pretty equivalent. What happens if you switch? So if you say you failed one drug and you tried, so you failed methotrexate, you went to mycophenolate. Now this is quite interesting. The bottom line is that if you failed mycophenolate and you switched to methotrexate, you could still get success at about 70%, but not the other way round. So if methotrexate's failed, there's no point probably using mycophenolate. So you might think of mycophenolate a bit a milder drug, a bit less efficacious. So has it influenced my practice? Well, it has. I'm using a bit more methotrexate than I ever used before, and probably less Cellcept. And this is a great study. We needed this done 20 years ago. It's a proper randomized controlled study. So it will influence practice. And these are all off-patent, cheap drugs. Okay, what about biologicals? Well, we have good data now for Humira from the visual studies. These are first-rank, multi-center prospective studies that will have influenced our practice. Interesting study, they had 217 patients. The patients had a very rapid steroid taper. They were just forced to taper off the steroids. They were given Humira, or adalimumab, versus placebo, and they had some endpoints. And this is you'll see this graph again and again and again at presentations. This is the time to failure, clearly higher from day one in the placebo versus the Humira group, okay? Landmark study. And these were some of the aspects. They didn't look at CMO, so they looked at vitreous haze, new lesions, acuity, and AC activity. And each one, there was a lower likelihood of failure with the adalimumab group, okay? So every orange line is below the green. Landmark study. Visual 2, something similar. That was looking at patients with inactive uveitis with a sort of low dose to see whether they could taper successfully. So these patients, visual 1 was active, visual 2 was inactive, and again, 1-to-1, head-to-head, showed pretty well the same results. So the orange is the treatment line. This is time to failure, higher. Again, there was less reactivation because there were sort of more stable patients. But again, highly significant. So what about real-life experience? So this has influenced policy all over the world in terms of our evidence base for anti-TNF. What do the trials tell us and what do they not tell us? Well, this is quite a good book, actually, and it says happy families are all alike, unhappy families are all sort of different in their own way. And what that means is every patient fails in their own way. And you can't, it's difficult to individualize from trials. So, for example, you might put a patient on Humira, it might control the AC activity very well. The vitreitis may be remarkably better, but they may end up with a new lesion, 2 months' time. So they've failed in that respect. Or CMO, or you may have control of CMO, but quite an active anterior uveitis. So this is what we're kind of learning. And there's very little way of predicting that. So here's a case example of a patient, white male, bilateral panuveitis with disc swelling edema, likely sarcoid, but they couldn't find any systemic involvement. Had a normal brain MRI. He had, we tried prednisolone, we tried mycophenolate. Maybe these days we might have tried methotrexate, but this is before the results of our FAST trial. But we tried mycophenolate, still had edema. So he's failed steroids and conventional drug. There's his macular edema. 6 weeks of Humira. His bioscores improved. And there is his macula, nice and dry after initiating Humira. One of the problems with the visual trials is that there are many different diseases in these trials. I mean, the drug company was smart. They said, bring it in. Anyone can enter pretty well. Non-infectious. So they had a few Birdshot patients, a few Behçet's, a few VKH, idiopathic sarcoid, a whole mixed bag. Most were idiopathic. They had quite a few Birdshot patients, yeah. So it tells us that anti-TNF, probably, well, my experience is that anti-TNF works in Birdshot. VKH, smaller numbers of other diseases. The trial numbers are too small to work out what diseases are best suited for different drugs. We can't answer that question. What about practical advice for those thinking of using anti-TNF? We have at Moorfields, we're lucky we have a very good pharmacy service. We have protocol. You must do an infection screen. You must exclude TB. Because anti-TNF agents are associated with explosive TB. So we do a chest X-ray, we do gamma interferon. If there's any suggestion, they go to a physician for investigation and treatment. You asked me about the MRI. If patients have intermediate uveitis, we do arrange for an MRI brain scan pre-anti-TNF. So basically, if they're a female or you think it's a high risk of a MS-associated condition, we do image them pre-Humira. We call that screening. It does throw up issues. I mean, we've identified a few likely demyelinating cases that we weren't aware of before. You can't use Humira in MS because there's a risk of exacerbation. What do we tell patients about side effects? Well, I mean, it's great having a trial, but what they want to know, what kind of effects are they going to get? Well, we tell them that the drug is safe. There's no increased risk of cancer, for example. There's a slightly increased risk of infection that can be severe. We warn them about the TB risk. Our population in London, we have a lot of Asian patients, perhaps with sarcoid, and there is, a TB subset of that. They can get a lupus-like syndrome sometimes, and they can have raised ALT, raised liver enzymes as well. For time purposes, if you're interested in JIA-associated uveitis, the Sycamore study, again, shows efficacy of Humira. I'm not going to dwell on that for the interest of time, but our pediatric colleagues, this is Landmark, again, multi-center UK study. Okay, moving on. So what about some other drugs? Well, the evidence data is not so good. We've got some anti-TNF type drugs. We've got golimumab, not great data. This is a humanized anti-TNF, level 3. This is really just case series. We don't have anything like the evidence. There's some efficacy there. Infliximab has been around a very long time. It's given by IV. It's an anti-TNF drug. There's no level 1. There's no randomized controlled trials. There's a bit of use, level 2, looking at uveitis and Behçet's. That seem to show efficacy, and then there's a whole load of case series as well. So quite low level sort of data for infliximab, but you can use it, particularly if patients perhaps failed Humira. You might consider just switching between agents. You can get effect. Talk for a few more minutes because I'm conscious we're running over a bit, but some of the other sort of cytokine blockers. Okay, we've got some of the interleukins, which are of interest. Nothing that has anything like the evidence base for anti-TNF. IL-1, gevokizumab, it's given by IV or subcut. It is used in some type 2 diabetes, actually. The iGuard study, which was a few years ago in Behçet's, and that failed to reach its endpoint. It terminated early, so it didn't seem to work. Dicluzumab, again, this was withdrawn because of safety concerns. They had inflammatory brain disorders with this agent, an IL-2 drug, so that's off the market. Again, there were some studies, kind of level 3, quite poor studies, really. IL-6, tocilizumab. We do use it sometimes. We use it for sort of resistant macular edema. It is of interest. There is a good track record. It's used in rheumatoid. Giant cell arteritis shows efficacy. IV or subcutaneous. It's an IL-6 antibody. There was a level 2 study which showed a sort of 50%. It wasn't particularly impressive, but showed some efficacy. And then there's some level 3 kind of case reports effectively. So I do sometimes use it in very resistant macular edema that's perhaps failed everything else, and some patients seem to respond. It's a funny drug that you can control the macular edema, but sometimes the uveitis, the anterior uveitis is untouched. So the AC activity continues. It's very good for sort of, it might be used for getting rid of macular edema. Rituximab, you'd be familiar with this drug, a very profound B-cell depleter used in lymphoma, used in rheumatoid disease sometimes, vasculitis, quite a profound, powerful, profound immune depleter. So there are for sure side effects, infusion-related, infections. A little bit of evidence in uveitis, level 2, used in Behçet's, and some case studies. We don't use it very much. I've used it for scleritis. If there's one condition that seems to be useful, it seems to be very resistant scleritis. But again, these are case series. We don't have great data. It's a shame. It'd be lovely to have methotrexate versus rituximab or something for your scleritis. Touching on interferons, they've been around a long time. You've got the alpha interferons. They're given subcutaneous. Good evidence for use in Behçet's, not for uveitis, but for controlling the systemic manifestations. Patients get flu-like symptoms, and that's actually, you want to see that because that's a mark that you're getting an effect. And then there's always this concern about the mood changes. This is the thing that freaks clinicians out, but there is an increased suicide risk and a negativity against on mood. So you have to screen these patients psychologically. You have to know what you're doing. And other LFT abnormalities. There's been a trial in Behçet's with Suleitman. Failed to meet its primary endpoint, unfortunately. Christine Fardo has used it in birdshot with some success. Again, it wasn't a randomized control trial. The Bogody in Paris. So level 3, again, small numbers and no control. Just touching on what's new, I put this up because this is very topical. There's something called JAK2 inhibitors, and I'm sure we're going to see a lot more about these drugs. It's a protein kinase inhibitor. This is basically a protein kinase. A lot of cytokines act on this. So this is the end kind of pathway. So you can inhibit this. You can inhibit your end pathway of inflammation. So a lot of cytokines inhibit this. So there's good evidence of use in rheumatoid and psoriasis, Crohn's disease, ulcerative colitis. Do we have any data in uveitis? Well, there's just one case report published this year. 2 patients, both did well. But I think we're going to see a lot more about this drug, the JAK2 kinase inhibitors, in the next few years. I mean, if we start from level 3, we've got to work up to a level 2 and take it from there. But you may see a little bit more about JAK. This is tofacitinib, used in rheumatoid primarily. We can take questions, or maybe we should call it a day.
I think that we can break for lunch, yeah. And I remind that there's lunch with the experts. So if you have any questions, you are very welcome to do that upstairs.
Okay, thank you very much.